And so I want to acknowledge Ken, and I won't be choked up the rest of the day. So, Dr. Lin, I'm going to turn it over to you as moderator of the brain cancer section, and also you're bringing Dr. Lee on board. Thank you so much.
Okay, so let's start the brain section. Dr. Lee will be the first speaker. Okay, she's going to, so she's going to control the slides. Dr. Lee, you can share your slides now.
Can you see it?
Yes. Oh, you need to, yes, move to the other side.
Okay.
Okay, that's good.
Great. Thank you so much for the very kind introduction by Dr. Ink. And I also like to thank the organizing committee, particularly Dr. Lin, for the invitation. It is a great honor to have this opportunity to speak with you on a topic that I felt particularly passionate about, which is management of the brain metastasis. So these are my disclosures and learning objectives. So there are 4 areas I would like to focus on for today's presentation. I will review the most recent updates in each area and discuss the controversies and future directions. So those areas are management of multiple brain metastasis, management of resection cavity, incorporation of brain radiation with immunotherapy and target therapy. So the first subject is management of multiple brain metastasis. We all know that whole brain radiation has been around for forever. It's widely available. It can treat microscopic as well as gross disease. However, it's associated with significant cognitive side effects, and it can cause interruption of systemic therapy by at least 4 to 6 weeks in a patient population that oftentimes needs systemic therapy for their extracranial progression. So I'm sorry, this is, okay. On the other hand, stereotactic surgery spares normal brain. It's a one-day procedure. It causes minimal break in systemic therapy. However, it does not address microscopic tumor. It's limited by the number and size of lesions we can treat. It does require close surveillance and salvage treatment. So there have been at least 4 or 5 randomized trials evaluating the role of whole brain radiation in patients with 1 to 3 or 1 to 4 brain metastasis. The 2 trials I listed here are particularly important because they used cognitive function as the primary endpoint for the evaluation, as cognitive function was increasingly recognized as an important outcome for this particular patient population. So the first trial was performed by Dr. Eric Chen when he was at MD Anderson Cancer Center. So the trial was terminated early after a planned interim analysis showing that addition of whole brain radiation caused cognitive decline without prolonged patients' overall survival. These results are subsequently confirmed in a larger trial run by Alliance. So the Alliance trial again showed that when you add whole brain radiation, patient has worse cognitive decline, and even though whole brain radiation helps with the local intracranial control, it does not prolong patient survival. So these trials established SRS as the standard of care for patients with 1 to 3 brain metastasis. How about patients with 4 or more brain metastasis? Can we use SRS? For the longest time, the only evidence we have is this Japanese registry study where patients with 1 to 10 brain metastasis were treated with SRS. The goal of the trial was compare the overall survival of patients with 2 to 4 mets versus those with 5 to 10. They were not able to observe a difference between those two cohorts. As you can see, the overall survival is about 11 months. So they cautiously concluded that SRS might be a suitable alternative for patients with up to 10 brain metastases. So, but keep in mind, this is an observational study. We still had no level 1 evidence to support the use of SRS in patients with 5 or more brain metastases. And this is why we launched a phase 3 randomized trial in patients with 4 to 15 brain metastases in 2012. So that was 8 years ago. So the patients were randomized to whole brain or SRS. The primary endpoint of the trial was memory decline at 4 months as measured by Hopkins Verbal Learning Test, the total recall. So the other primary endpoint was local control. So we closed this trial early after achieving about 70% of the accrual goal. And in a few slides, I will explain to you why. So basically between September 2012 and September 2019, 72 patients were randomized with a median follow-up of about 6-7 months. The median number of brain metastases at the time of enrollment is 8. 62% of the patients in the whole brain radiation arm received Memantine. So now looking at the results of the primary endpoint, which is HVLT at 4 months, we observed a statistically significant difference between the two arms in favor of SRS arm. Basically, the patients who received SRS had a better memory at 4 months compared to patients who received whole brain radiation. So not only there's statistical significance, if you look at the actual size of the benefit, is also clinically meaningful. We also looked at a composite score combining different tests, which gave us a better global assessment of patients' overall cognitive function. We also observed that statistically significant, clinically meaningful difference between the two arms, again, in favor of SRS. So for the other endpoints, we did not observe any difference in overall survival. The local control at 4 months was not different. Time to distant brain failure was different in the numerically, but did not reach statistic significance. So more detailed results will be presented at ASTRO in October. And I would appreciate if you don't share these results outside this conference. So as I mentioned earlier, Memantine was used in 62% of the patients who were enrolled in our trial. And this is because in 2017, Paul Brown published the Memantine trial, which is a phase 3 trial in patients who received whole brain radiation. They were randomized to receive placebo and Memantine. Memantine showed showed that patient lead to superior memory, speed of processing, and executive function. So it became the standard of care for patients who need whole brain radiation. So after that, we encouraged our patients on the trial to take Memantine, but we didn't mandate it. So my whole brain versus gamma knife trial endured 2 practice changes during its course of 8 years of running. So the second practice change was related to hippocampal avoidance whole brain radiation. So NRG launched the study based on a very successful phase 2 study by RTOG. So this is a phase 3 trial comparing whole brain radiation with Memantine versus hippocampal avoidance whole brain radiation with Memantine. The key eligibility criteria is that patients could not have metastasis within 5 millimeters of hippocampi. So this trial was published earlier this year in JCO. It is a positive trial. So hippocampal avoidance whole brain radiation is associated with prolonged time to cognitive failure and a better patient-reported outcome. Symptoms such as fatigue, difficulty with speaking, and there's no difference in overall survival or treatment-related toxicity. So this is exactly why we terminated our trial in September last year. MD Anderson was one of the sites for NRG-CC001, so we were aware of the trial results, and we knew that it was going to be practice changing, which was why we terminated our internal trial. Fortunately, we were able to pick up a signal between the two arms, even with incomplete accrual. So now we have 2 treatment options. So with hippocampal sparing with memantine, we have level 1 evidence to support its use in patients who need whole brain radiation. On the other hand, we have a phase 3 trial supporting the use of stereotactic radiosurgery in patients with 4 to 15 brain metastases. Which one would you offer to the patient? Say, if you have a patient with 10 brain metastases, what would you do? So this is the question we face daily in our clinic, and it's also the question we discuss at our weekly Brain Mets tumor board. So fortunately, there is a phase 3 randomized trial ongoing right now, run by the Canadian Clinical Trial Group. So the Canadian Clinical Trial Group actually 2 years ago launched a trial comparing SRS and whole brain radiation for 5 to 15 brain mets. So it's basically very similar to the MD Anderson in-house trial. However, shortly after they activated the trial, the NRG-CC001 results became available. So they converted this trial to SRS versus hippocampal avoidance whole brain radiation. So that trial is currently open for accrual in the US. It's open through Alliance and NRG group. So within MD Anderson, we're also in the process of developing a trial that's similar but a little bit different from this Canadian group trial. So now moving on to the second area of interest, management of resection cavity. In 2017, 2 phase 3 randomized trials were published back-to-back in Lancet Oncology. The first trial was MD Anderson in-house trial in patients with 1 to 3 metastases. After gross total resection of at least 1 metastasis, the cavity was randomized to FRS versus observation. The second trial is an NCCTG trial in patients with 1 to 4 mets. After resection, the gross total resection was not required. The cavity was randomized to SRS versus whole brain radiation. So the MD Anderson trial, where the cavity was randomized to SRS versus observation, the primary endpoint was local control. So it is a positive trial. The addition of SRS to the surgical cavity does reduce local recurrence. 1 year freedom from local control, from local recurrence is 43% versus 72% in favor of SRS. There is really no difference in toxicity between the two.
That's $200.
So the NCCTG trial, where the cavity was randomized to SRS and whole brain radiation. The primary endpoint was cognitive function, as shown in the curve on the left side, which represents cognitive deterioration-free survival. You can clearly see the separation of the 2 curves. At 6 months, the patients with cognitive deterioration was 85% for the whole brain radiation arm versus 52% for the SRS arm. Even though, again, whole brain radiation was able to improve intracranial control, it does not translate into a survival benefit. So based on these 2 studies, the SRS became the standard of care for the surgical cavity due to improved local control as compared to observation and better cognitive preservation as compared to whole brain radiation. But that's not the end of the story. There's still unanswered questions related to the cavity treatment. And one of them is the risk of LMD, and the other is what is the best radiation regimen for the cavity. As we all know, during the surgical resection, there's a risk of tumor spillage into the CSF or the ventricle. At least 1 in 7 patients who underwent resection of metastasis followed by radiation develop LMD. Even with post-op SRS to the surgical cavity, the risk of LMD can be as high as 28%. So in our in-house trial, comparing SRS with observation, the risk of LMD was about 20% for the whole population, so which is pretty high. On the other hand, in retrospective series, the risk of LMD can be as low as 3 or 4% in patients who received pre-op SRS. So the idea is that if you radiate the tumor first, even if there's tumor spillage during the resection, those tumor cells are dying or they're impaired, so it's unlikely that they will survive in the CSF. So for that reason, we launched a phase 3 randomized trial within MD Anderson Cancer Center comparing post-op versus pre-op SRS. The trial was led by one of our star junior faculty, Dr. Yeboah. It has been accruing very well. So hopefully we will be able to provide answer to this in the near future. So the other question is, what is the best radiation regimen for the cavity? Why are we asking that question? So let's go back to the NCCTG trial where they compared the cavity. They compared the whole brain versus SRS for the cavity. So when they look at the surgical bed control, they did not see a difference up until 9 months. And as you can see, at 9 months, there is separation of the 2 curves representing the surgical bed control. What was surprising was that the local control was better with whole brain radiation, not SRS. So this is surprising because we think that with SRS, we drop more dose to the surgical cavity, we should have a better or more durable control. That apparently is not the case. So what could have caused this? So one possibility is SRS-associated radiation necrosis. So the radiation necrosis sometimes can be interpreted as tumor recurrence. So another possibility is that the delineation of the surgical cavity. So for those of us who treat cavity on a regular basis, we know that it is challenging sometimes to delineate the extent of the surgical cavity. It's not always to decide where the cavity ends, where the sulcus starts. And with SRS, you do have a sharp dose fall off outside your target. So if you do not contour the cavity, you basically are not treating it. So is this increase the risk of recurrence due to the target delineation? So another possibility is that whether the biology is different, between different regimen. So when you look at the surgical bed control in the literature, as you see, there seems to be a better surgical bed control when fractionated SRS was used, as shown on the right side of your screen. So I know you cannot really compare different studies. However, but you can at least appreciate a trend. On the left side is single fraction SRS, and on the right side is the fractionated treatment. It seems that the surgical bed control is better. So if you think about it, we oftentimes determine whether we want to do single fraction or fractionated based on the size of the cavity. So the cavity that was treated with fractionated tend to be larger. So technically they could have a higher chance of having recurrence, but that's not the case. There's actually better local control when you use fractionated SRS. So that led to a new phase 3 trial launched by Alliance, comparing single fraction SRS versus fractionated SRS to the surgical cavity in 3 to 5 fractions based on the volume. So hopefully we will, from this study, we will be able to figure out, what is the best regimen for the cavity. So in parallel with those efforts, there are some preclinical studies also provide evidence to support the use of fractionated treatment. in terms of inducing immune response. So the studies in the next few slides were performed by Dr. Fomenti and Dr. DiMario at Columbia University. So in this particular study, the tumor cells are injected into both flanks of the mice, and only one tumor is radiated. It's termed as primary tumor. And they examined the different radiation regimen, 20 gray in 1 fraction, 8 gray times 3, and 6 gray times 5. And they observed what happens with the unradiated tumor, which they call the secondary tumor here. So this is a very busy slide, but I want you to focus your attention on the 3 red arrows, because those represent the change in the size of the unradiated tumor. So as you can see, with 20 gray times 1, you don't see any really change in the secondary tumor. However, when you use 8 gray times 3, you see a significant growth delay in the unradiated tumor. And when you use 6 gray times 5, you also see a drop of the size of the unradiated tumor. So this basically showed that fractionated treatment appears to do a better job in enhancing the abscopal effect from radiation. So what was really interesting was that the same lab was able to fold the mechanisms of how that happens. So basically, the mechanism goes as following. So when you radiate a tumor, we all know that we generate double-stranded DNA fragments. And those double-stranded DNA fragments can trigger a STING pathway, which lead to interferon induction and immune response within the tumor. So this is basically how radiation can turn tumor into an in situ vaccine. However, that effect is dose dependent. When you go beyond 12 gray, you do not see really those double-strand DNA fragments. The reason is that at that dose, you induce the production of an enzyme called TREX1, which chops up all the double-stranded DNA fragment. So that is why when you use a single fraction large dose, you do not induce a very strong immune response. So these studies provide evidence to use fractionated treatment to generate a better immune response than single fraction. So I thought this was such a beautiful story, from the initial observation to uncovering of the mechanisms. Now moving on to the role of brain radiation in the era of immunotherapy. So 2 years ago, 2 phase 2 trials published in New England Journal of Medicine examining the efficacy of ipi/nivo in the treatment of melanoma brain metastasis. So the first trial was led by my medical oncology colleague at MD Anderson Cancer Center, that's Dr. Taubey. So this trial basically showed that ipi/nivo is associated with an intracranial response rate of 56%. They also find this intracranial response basically parallels the extracranial response, but a little bit less, about 10% less. And they also found in patients who responded, the response tend to be durable. So the second trial was led by Australian group. They basically showed similar results with the intracranial response rate of 46%. So these studies has led to many medical oncologists to believe that the standard of care of melanoma brain metastasis should be ipi/nivo. And they stopped referring patients for radiation. So the question is whether a phase 2 trial with a response rate of 50% good enough to de-escalate management of brain metastasis. Is it enough to omit a standard of care of SRS, which has a local control of 70 to 90+%? And when you look at the literature with SRS combined with immunotherapy, the local control is over 90%. So should we hold the radiation because of, intracranial response rate of 50%? So my answer is no. I think we need evidence to really delineate the efficacy of radiation in upfront setting and salvage setting. So another concern I have with omitting upfront radiation is that about 50% of the patients do not respond in the brain. We have no way at this moment of identifying which patient is going to respond, which will not. So the question is, when you omit radiation in those patients and you treat them at the time of progression, did we miss the best window of opportunity to achieve intracranial in those patients? So in my opinion, a phase 3 randomized trial comparing upfront SRS and salvage SRS in the setting of immunotherapy is needed. As far as I know, NRG is evaluating those concepts. And also it is important for medical oncologists to know that when you run a trial for brain tumor, it's important to include brain tumor specific endpoints such as cognitive function and prevention of additional treatment. So there are many very good rationales to combine radiation and immunotherapy. For example, as I mentioned earlier, radiation potentially turns tumor into in vivo vaccine by promoting tumor antigen release and stimulating T-cell mediated immune response. On the other hand, immunotherapy can turn radiation from local therapy to systemic therapy by enhancing radiation-induced abscopal effect, which is extremely uncommon on its own. So there are some evidence to actually support the combination of the two. And this is a study published by my medical oncology colleague, Dr. Davis from MD Anderson Cancer Center. So he did a molecular profiling of paired brain mets sample and extracranial sample. And what I'm showing you here is actually only a small fraction of his publication. So what he was able to identify was two populations of brain metastases, one with high immune infiltrates and one with low immune infiltrates. As you can see on the left side, the tumor cells, the brain metastases with high immune infiltrates is associated with better survival. And when he was trying to identify what patients tend to have high immune infiltrates, and the only factor that he was able to identify was prior radiation. So basically, radiation is associated with higher immune infiltrates in the brain metastases, which basically is the a more robust inflammation of those metastases, which in turn is associated with better survival. So another line of evidence came from one of our very talented residents who studied the overall survival of melanoma patients who received concurrent immunotherapy and SIS. It's a retrospective study. So we defined concurrent treatment as treatment of radiation and immunotherapy started within 30 days of each other. Specifically, he identified a relatively cleaner population of patients with newly diagnosed melanoma brain mets who received no prior immunotherapy or SIS. So he was able to show that in this patient population, those who received the two treatments within 11 days of each other have better overall survival, as shown on the left side, and a better distant brain control, as shown on the right side, as compared to patients who had an interval of 12 to 30 days between the two initiation of treatment. So basically, if you gave two treatments close in time, the patients are more likely, and I should say there is association between the better overall survival and the brain control if the two treatments are delivered within a shorter period of time. We did look at the sequencing of the two treatments. We did not see a difference. It's likely because the small sample size. Not surprisingly, we observed increased radiation necrosis when immunotherapy and SRS were delivered within a short period of time. So for patients who had two treatments within 11 days of each other, the risk for radiation necrosis is about 26% versus about 4% for patients who have a longer interval. And this is actually consistent with our previous publication showing that the rate of radiation necrosis is about 27% in melanoma patients who are treated with ipi/nivo and SRS. So this has been used by many of our medical oncologists as a reason not to offer brain radiation. And so my belief is that that really should not be used as the reason to not offer brain radiation. The reason is that, number one, radiation necrosis does not always cause symptoms. And in patients with symptoms, it's highly manageable. So it's a very manageable side effect. And in this slide, I'm showing you our management algorithm for suspected radiation necrosis. So we basically do not do anything if the patient does not have symptoms. If they have symptoms, we start with steroids. If they become steroids resistant or refractory, we do different imaging studies to give us some idea whether those patients will have radiation necrosis or tumor recurrence. Based on the imaging results, if patient we believe they have radiation necrosis, we start treatment with Avastin or laser ablation. If they had recurrent tumor, oftentimes they go to resection if it's resectable. If it's not, they get laser ablation. So it is a very highly manageable side effects. And also for all the data that I've shown you so far, the radiation necrosis represents an inflammatory response. So it might actually indicate better survival for those patients. So if I'm a patient, I'd rather to deal with the side effects of radiation or radiation necrosis and have the tumor controlled. So we therefore launched a phase 1/2 trial 4 years ago, evaluating the safety and efficacy of concurrent nivo/ipi with brain radiation. So the radiation can be either SRS or whole brain radiation as determined by the treating physician. And the concurrent treatment is defined as initiation of treatment within 7 days of each other. We didn't define the sequence. Each treatment can start first. And the DLT is defined 15% of intracranial toxicity or 30% of extracranial toxicity assessed at 8 weeks. So we have completed the phase 1 portion of the SRS cohort, and we will be presenting these results at upcoming ASTRO. Basically, we did not reach the predefined DLT, indicating that it is safe to combine ipi/nivo and SRS for non-small cell lung cancer patients with intracranial metastasis. So the completion of this part of the study is very timely because earlier this year and also later last year, the 2 phase 3 randomized trials were published, establishing ipi/nivo as the first-line treatment for non-small cell lung cancer, advanced non-small lung cancer. So in the first trial, nivo/ipi was compared to chemotherapy and showed overall survival benefit. In the second trial, the comparison was made between nivo/ipi with 2 cycles of chemo versus chemo. And again, it showed overall survival benefit compared to chemotherapy. So as we all know, as Ipi and Nivo are anticipated to be used more as a first line for non-small cell lung cancer, and we know those patients tend to develop brain metastasis. So we are happy to be able to provide the phase 1 data to support the use of Ipi/Nivo with SIS. So now moving on to the fourth area of interest, the role of brain radiation in the area of CNS penetrating target therapy. As we all know, more and more targeted therapies have shown intracranial activity. Those include BRAF and MAP kinase inhibitors for melanoma, EGF receptor and ALK inhibitors in non-small cell lung cancer, and HER2 inhibitors for breast cancer. So first, I want to draw your attention to this retrospective studies led by Dr. Veronica Chang from Yale, inclusive of data from 6 institutions. So in this particular study, they looked at the patients who are eligible for EGF receptor inhibitors. They compared the overall survival of patients who received upfront radiation, whether SRS or whole brain radiation, versus those who were not receiving upfront radiation. So what they found is that there is association between omission of brain radiation and worse overall survival. So basically, patients who did not receive upfront radiation are more likely to die and die early. So, and I have used this trial to really caution my medical oncologist colleagues about omission of upfront brain radiation. However, that issue became a little more complicated because the newer agents have shown better CNS penetration, therefore better CNS activity. For example, Tagrisso has been shown to be better than the standard EGF receptor TKIs, and in this phase 3 trial, and they observed a similar benefit in patients with treated brain metastasis, suggesting that Tagrisso have activity in the brain as well. Along the same line, in a recent published phase 3 trial in HER2-positive breast cancer, we similarly observed intracranial activity with tucatinib. So this is a trial in HER2-positive breast cancer patients. The patients were treated with the standard of care of Herceptin and Xeloda, without tucatinib, which is a HER2 inhibitor. What's unique about this trial is that they allow patients with treated or untreated brain metastasis. And this trial is positive. It showed overall survival benefit with the addition of tucatinib. So what I'm showing you here is the subpopulation of patients with brain metastasis as shown on the left side. They observed overall survival benefit in this population, suggesting that tucatinib has activity in the brain. In addition, they also look at the patient population where the brain metastases were not treated with radiation. So those are the patients with untreated brain metastases. And as you can see, tucatinib is associated with better survival, meaning that it has intracranial activity as well. So again, we are at a time that we have, it is absolutely fantastic that we have more and more target agents that can penetrate into the brain and show efficacy in the brain. And the question still remains, can we safely hold radiation? So at least for the retrospective studies, we have learned that the holding of intracranial radiation can potentially lead to worse survival. And again, in my opinion, I think we need phase 3 trials to test that question. So in summary, For patients with multiple brain metastases, we have level 1 evidence to support the use of hippocampal avoidance whole brain radiation with memantine. And we also have emerging evidence, if confirmed, to support the use of SRS. So the next question is, among those two options, which one is better? So we have a Canadian trial that is ongoing to test that question. So the second one is the management of resection cavity. We have level 1 evidence to support the use of post-op SRS as the standard of care for the surgical cavity. We are evaluating the benefit of pre-op SRS in terms of reducing LMD for resectable brain metastases. And also the best SRS regimen is being evaluated in an alliance trial. So in terms of whether we should deliver radiation or not in patients getting immunotherapy, and this is basically very controversial issue. And in my opinion, I think we need phase 3 randomized trials to test the question whether the radiation can be safely omitted or not, or deferred. So fortunately, I believe NRG is interested in those concepts, and hopefully we will see trials ongoing in the near future. And lastly, we're facing the same issues with patients receiving CNS penetrating target therapy. So the question again is, can we safely hold the radiation in those patients? Or should we combine the treatment to give a better intracranial control for those patients? But at the same time, we may put the patient at a high risk for toxicity. So I don't know the answers to those questions, and hopefully, again, I would like to see a phase 3 trial to address those questions. Okay, I'm going to stop there. Thank you very much for your attention.
Thank you, Dr. Lee. That was a wonderful talk, complete and up to date. And please, we will bring you back at the panelist section. The next speaker will be Dr. Miki Kazu from Surgical Oncology Department. Dr. Kazu, are you here? Thank you.
Thank you for the opportunity given to me to present my lecture here. Okay. So good morning. We are going to talk about the management of spine tumors, mainly metastatic. I'm going to start off with some cases. This is an elderly male with metastatic esophageal cancer to the spine, presented 2 weeks after mild trauma with neck pain. You can see there is fracture at the base of C2 and the lytic lesion in C3. What should we do? Put him in a collar, halo, surgery. What kind? Should we biopsy it? We opted for a collar, but the patient didn't tolerate it. Now what? Should we fuse his head to the neck? He's having terrible neck pain. We decided to do something out of the ordinary for him. We wanted to save him from a big fusion surgery. We performed the first stereotactic CT image-guided combined biplanar fluoroscopy transoral C2 vertebroplasty. You can see the needle in the mouth of the patient and the navigation mask on his face. The cement fills up C2 and the patient's neck pain resolves completely. 2 days later, his lytic C3 vertebra fractured when he moved from one bed to another. What should we do now? Is it time to finally perform a big fusions procedure? The patient has severe neck pain. We performed 2 additional vertebroplasties in C3 and 4. the neck pain resolved completely. Patient selection is very important. It's much harder not to do the surgery than doing surgery when you see cord compression. Spinal oncology neurosurgeons should think about their patients from the perspective of an oncologist. See the patient as a whole and not just the cord compression, and I'm the neurosurgeon that needs to decompress. This is a patient with no cancer history, has 2 months of neck pain and intermittent numbness and tingling in hands and fingers. His motor exam is 5 out of 5. You can see severe cord compression from a lesion which is both epi and subdural. What should we do? Decompress emergently, electively, biopsy first? Let's imagine that he presents with some weakness. Now what? Should we decompress, biopsy? When to do the surgery? Should we start steroids? These are all questions that me as a spinal oncology neurosurgeon must think about while everybody around you is asking for answers. The ER, medical and radiation oncologist, the patient and his family. The patient went to an outside facility, then they performed the laminectomy, removed the tumor, opened the dura, didn't close it well, and came to us suffering from a severe positional headache due to a large pseudomeningocele and methotrexate toxicity due to its accumulation in the CSF. The pathology was a B-cell lymphoma. So now the patient needs to hold his chemotherapy, is having methotrexate toxicity, and needs to undergo another surgery to close the leak, have a lumbar drain for 15 days, and not addressing his new lymphoma diagnosis. Could have we avoided it? The patient was almost neurointact. We could have done a biopsy preoperatively, diagnosed the lymphoma, and treat him non-operatively. If you do surgery, you did not have to open the dura if you send frozen specimen. I'm just trying to show you why spinal oncology neurosurgeons have to think more like an oncologist and not always doing the obvious, decompressing the cord. This is a 58-year-old male, comes in with 12 hours of paraplegia, underwent emergent CT which showed this huge lesion in his chest wall and entering his spinal canal. We saw a large lesion in the scout image on the kidney. The patient did not tolerate the rest of the MRI. You can see there are large blood vessels in the tumor. What should we do now? Rush to surgery? Anything else before surgery? What to expect from an RCC met? Is it the same as a breast cancer met? Embolization of the tumor is very important. RCC mets are notoriously bloody. Even with embolization, the patient blood loss was 8 liters and had a 14-hour surgery. We can see the 2-lever corpectomy and cage insertion. On the bottom left, we can see the postoperative MRI. We can't see a lot, right? Many artifacts. How can we follow for recurrence? We'll talk about it later. Now something that requires a completely different approach. This is a 52-year-old female suffers from back pain and left lower extremity radiculopathy. Biopsy revealed the chondrosarcoma. This is the lesion. What should we do now? That's not a metastatic lesion. This is a primary bone tumor. Potentially we can cure the patient. This patient requires an en bloc vertebrectomy. We start by performing a laminectomy. This is the lamina removed in one piece, putting screws and rods, and then going to the front and removing the vertebral body in one piece. That's the vertebral body with the lesion. So before we are talking about the actual decision-making process, we will talk about the goals of therapy. In metastatic disease, the goals are largely palliative. They have a systemic disease which has to be controlled with systemic therapy, and we are talking about a focal problem in their spine. We want to improve or at least maintain neurologic function through spinal cord decompression, either with surgery, radiotherapy, or systemic therapy. Stabilize an unstable spine and provide pain control will improve the quality of life. Finally, it's local tumor control, making sure after we perform surgery, the tumor is not coming back anytime soon, and we do that by some kind of radiation therapy. We have plenty of options to treat these patients, and the 3 broad categories are systemic therapy, radiation therapy, and surgery. Systemic therapy is evolving every day, and there are new targeted therapies that are really changing survival in some patients. Radiation therapy has evolved over several decades. We still offer conventional radiation therapy to certain patients who we think are going to respond to conventional radiation, but we can also offer stereotactic therapy. From surgical point of view, we have the percutaneous cement augmentation for compression fractures causing mechanical pain only, and block surgery for primary bone tumors or occasionally oligometastatic disease. Intralesional surgery is when you go into the tumor with instruments and debulk it, and it's mainly done for metastatic disease, where it's called separation surgery. This all can be done by a minimally invasive oncological spine surgery approach called MIOS, or through the traditional open approach. There are 18,000 new cases of spinal metastases a year. In the famous Pachel study, where we actually looked at the compressive surgery plus RT versus RT alone for patients presenting with spinal cord compression from metastatic disease, the primary endpoint was the ability to walk after treatment. In every criteria measured, the patients who received surgery plus RT did better than the patients who received the radiotherapy alone. Now we are able to approach the spine from a variety of trajectories and put it back together after we're done. This is a 4-level vertebrectomy for breast cancer met. A surgery we were not able to do in the past is now possible. It's hard to decide who will benefit from surgery. There are many classification systems described for that. This is what goes around in a surgeon's brain when he needs to decide about surgery or not. Neurosurgeons and radiation oncologists improved a lot in their collaboration in planning the radiation and decision about the best treatment plan for the patient. Conventional radiotherapy is not used that often anymore. SRT is really a game changer in the treatment of spinal metastases. We don't have to radiate all the field and the organs in the way of radiation. Radio-resistant tumors suddenly became radiosensitive. SRT is limited in the case of spinal cord compression. In order to hit the tumor with high dose, we need to have space between the cord and the tumor. Here, the neurosurgeons come into the game. During my fellowship, I took part in the study done at the Ohio State University. It's currently under review about postoperative SBRT for spinal metastases. We analyzed local control, progression-free survival, overall survival, and toxicity. The most common regimen was 27 Gray in 3 fractions. Most of the patients underwent vertebrectomy in the thoracic spine, were embolized. Mostly more than 2 levels were involved, and the RT extent was circumferential. We saw that performing SRS less than 40 days after surgery improved the 1-year local control from 75 to 95%, and also that preoperative embolization improved local control. RCC had the best local control. This is a meta-analysis of recent papers about SRS showing 88% of symptom control and 87% of local control. Post-SRS compression fracture is a known complication. We can perform prophylactic vertebroplasties on some occasions, although I'm not a big fan of these. Factors shown to contribute for developing fractures are osteolytic tumors, significant involvement of the vertebral body, pre-SRT fracture, and to some point the dose per fraction. We can safely deliver SRT following conventional radiotherapy with no increased incidence of post-radiation toxicity. So let's try and put together how do we evaluate the patient. How do we make these decisions and how do we integrate all the possibilities, the systemic burden of the disease, the various radiation and surgical options? Is the NOS paradigm. Is the 4 things that we think about every time we see a patient with spinal metastases. The extent of the epidural disease is important in deciding whether the patient needs some kind of surgery or not. Mostly grades 1C, 2, and 3 need surgical intervention, whether separation surgery or vertebrectomy, unless it's a very radiosensitive tumor without instability or neurological compromise. Clearly, radiation won't fix this problem. So we had to perform a vertebrectomy. The oncologic looks at the primary tumor histology and trying to predict how responsive the tumor is going to be to therapy, which leads us to the next important factor. We need to establish a diagnosis. We need to know what we are treating. What is it? A MET, a primary tumor, infection, pseudoprogression? We need to get a biopsy. All these factors on the list are determined by the tumor histology, and we should tailor the surgical and non-surgical approach based on that. What is it? A chordoma? Does it need an en bloc surgery? That's an ependymoma that requires a totally different approach. You also would like to know if it's a bloody tumor or not. Surgery for RCC is different than surgery for a breast met. There are several options to obtain a biopsy. One very important thing, always think about the tract. Can you resect the biopsy tract? On the right, biopsy for a chordoma. The easiest way is to go transrectal, but then how you resect it. On the left, another chordoma. Should we go through the mouth? Can we resect it? Just an example of tract resection. If we put the neurologic and oncologic together, this is the plot that we get. Any patient with a radiosensitive tumor, regardless of the degree of epidural extension or cord compression, unless they are neurologically deteriorate in front of your eyes, can safely undergo conventional radiation. On the other hand, patients with low-grade ESCC with radio-resistant tumors will not respond well to conventional radiation, and these will require SRS for tumor control. The patients with high-grade ESCC and radio-resistant histology will need most likely separation surgery followed by SRS. The goal is to reduce the risk of radiating the neural structures by creating a space. Not every tumor type is allowing us to perform separation surgery, as I will explain later. Then we assess mechanical instability with the spinal instability neoplastic score. And this is a separate indication for surgery because no matter how sensitive is the tumor to radiation, if the spine is unstable, it has to be stabilized. We won't be able to do that with systemic therapy or radiation. This is SINS 13, but we don't need a SINS score to see the instability. And then we look at the patient as a whole. We need to know whether our patients can tolerate surgery. These are very sick patients. We have some scoring systems to help us evaluate the life expectancy of the patients. Some of these are outdated because they don't consider the specific response of the patient to modern chemoimmunotherapy. This is the reason we need multidisciplinary tumor boards where we discuss with medical oncology, radiation oncology, that what we are proposing is actually reasonable in the context of what this patient requires. Two famous ones are the Tobit and the Rebbeis-Takahashi score. They give us an estimate of life expectancy and the recommendation of treatment strategy.